Welcome everyone. Today we're jumping on a high-yield tour of some seriously tricky vascular anatomy. You know, the kind of stuff, the landmarks, the variants, that always seems to pop up on exams. Let's get right into it.
All right, let's kick things off with a classic board-style question. When does the axillary artery become the brachial artery? I mean, where's that exact line? If you're scratching your head a bit, no worries. By the end of this, you'll have it down cold.
So, here's the game plan for our tour today. First, we're going to tackle the arm's artery roadmap. Then we'll head down to the leg. After that, we'll see what happens when veins have to create some crazy bypasses. We'll also spot a few classic venous variants, and then wrap it all up with a little trivia to make sure everything sticks. Okay, first stop on our tour, the arm's artery roadmap. We're going to trace the whole path, right from the neck all the way down to the hand. And we're really going to focus on those name changes, because that's exactly what they love to test you on.
Now, this right here is a super important relationship, a classic anatomy trap. The subclavian vein, it runs in front of the scalene triangle. But the subclavian artery, it runs right through the triangle, hanging out with the brachial plexus. It seems like a small detail, but trust me, this is an absolutely high-yield point for any exam.
Okay, so let's play what I call the artery name game. We start with the subclavian artery, right? As soon as it passes the first rib, boom, it gets a new name, the axillary artery. Then it keeps going until it hits the lower border of the teres major muscle. And yeah, remember, it's the major, not the minor, and once it crosses that line, it becomes the brachial artery. This progression, this flow, it's everything.
So eventually, that brachial artery splits. The big question is, how can you tell the ulnar from the radial artery when you're looking at an angiogram? Well, here are 3 awesome tricks. 1. The ulnar artery is usually the bigger of the two. 2. It's usually the one that gives off the common interosseous branch. And 3, it typically supplies the superficial palmar arch. Super handy tips to keep in your back pocket.
All right, let's head south for our next stop. We're moving on to the leg's artery roadmap. And you'll see, we're using the exact same landmark principle we just used for the arm. It's all about those key locations.
So this journey starts with the external iliac artery. The second it passes the inguinal ligament, its name changes to the common femoral artery. That then splits into the deep femoral and the superficial femoral artery, the SFA. And once that SFA exits the adductor canal, bam, it gets a new identity as the popliteal artery. You see the pattern here, right? It's all about those landmarks.
And now for the grand finale. Down in the lower leg, this is where it can get a little tricky. The popliteal artery divides. The very first branch it gives off is the anterior tibialis. What's left is called the tibio-peroneal trunk. And that trunk then splits into the posterior tibialis and the fibular, which you'll also hear called the peroneal arteries. Seriously, knowing this branching pattern is absolutely crucial. Okay, time for a quick pop quiz. Based on what we just mapped out, what's the most medial artery in the leg? Think about it for a sec.
And the answer is the posterior tibial artery. That's the one. And just think about its path, right? This is the artery where you can feel for a pulse just behind the medial malleolus. You know, on the inside of your ankle. Super useful.
Okay, let's switch gears completely now. We've done arteries, let's talk veins. And to do that, I want you to imagine a massive traffic jam, but it's inside the liver. That's kind of what portal hypertension is. The blood can't get through, so the body has to get creative and build all these detours or collaterals to get around the jam.
One of the most famous detours you'll see is the formation of gastric varices. This is where blood gets shunted away from the liver. Now, if you're studying for an exam, listen up. The vessel they almost always show in this scenario is the left gastric vein, which is also called the quaternary vein. You got to remember that one. It's the main player here.
All right, let's move on to spotting some really common venous variants. We call these Aunt Minnies. You know, it's like seeing your Aunt Minnie in a crowd. You recognize her instantly. No question about it. These are classic, unmistakable findings that you just have to know on sight.
First up is a duplicated superior vena cava, or SVC. This is actually the most common congenital venous anomaly you'll see in the chest. And it's pretty much always a duplication. You get both a left and a right SVC. The key detail? That left SVC almost always drains right into the coronary sinus. Next on our Aunt Minnie list is a duplicated inferior vena cava, or IVC. For this one, there are 2 really important things you need to lock in. First, its classic appearance, which you're about to see. And second, its very strong link to renal anomalies, especially a horseshoe kidney.
And here it is. This is that classic look. I want you to remember this awesome little saying to burn it into your brain. The IVCs are the bread, the aorta is the cheese. You can see it, right? The two IVCs are on either side like two slices of bread, with the aorta squished in the middle like the cheese. Once you see it that way, you can't unsee it.
Okay, our last Aunt Minnie is the Azygos continuation of the IVC. So what does that mean? It's actually pretty simple. The hepatic part of the IVC is just missing. And the single most important clinical association you have to know for this one is polysplenia.
That's the big one.
All right, you've made it to the end. It's time for a little testable trivia. We're going to do a quick lightning round to make absolutely sure these high-yield facts are locked and loaded for your next exam. You ready for this? Let's go.
First up, what's the landmark for where the axillary artery begins?
The first rib. That's it. The subclavian artery becomes the axillary artery right at the first rib. Perfect.
Okay, next one. A duplicated IVC. It's strongly associated with problems in what other organ system?
The renal system, exactly. Remember that connection. You see a duplicated IVC, you should immediately think about potential kidney issues, like a horseshoe kidney.
So there you have it. You've just navigated some of the trickiest vascular superhighways in the body, and you spotted those classic Aunt Minnie variants. You've really learned to recognize these little glitches in the human machine. The only question left is, what glitch are you going to uncover next?